Good morning and welcome to the November Cyber Mentoring session. Once again, we have our wonderful partners, Doctors Hospital at Renaissance, who are going to join us today and present the topic, Stop the Bleed. One thing that I want to remind you is that this is being recorded and it will be put up on my YouTube channel sometime later this afternoon. For people who weren't able to join us live, they can watch the recorded version. One of the benefits of you being able to watch us live is there's a chat feature. So instructors, if you go to the bottom of the page, you'll see one of the icons is chat. And if you have any questions while the presentation is going on, you can type your questions into the chat portion and we'll be able to answer them as we go along. We'll ask our guest, Jennifer Volsey, to take a breath once in a while so we can ask some of those questions. We may also have time to unmute you and let any students who are brave enough to come up to the camera and ask their questions live to be able to do that. So I want to welcome you. We're very excited to get this started. I want to introduce Jennifer Volsey. She's a nurse at DHR. Jennifer, the floor is yours.
Hi, good morning. Like she said, my name is Jennifer Volsey. I am one of the trauma nurses here at DHR, and I'm basically going to give you a presentation of what I do here at the trauma center. So hopefully I can inspire some of you to become either trauma nurses or maybe a trauma surgeon or anything in the medical field. That way you can kind of see what it is that we do or that I do here at the trauma center. So I'm going to go over a few, couple of things. I'm going to bring up a slide in a couple of minutes. That way I can do my presentation. And then at the end, I'll open up for some questions. All right. Okay. All right. So this is the title of my presentation, Trauma Nursing, and I'm going to take you through. Here's a little bit about myself. So you see a couple of graphic pictures on there. I am a Valley native. I went to PSJ North High School, graduated from FAR back in quite a while now. After high school, I went ahead and went into the Air Force. After high school, I really didn't know what I wanted to do. So going into the Air Force gave me a leadway to kind of get out there, go see life outside the Valley and see what else was out there for me. While in the Air Force, I ended up working in San Antonio at a medical center as a medical technician. While being there, that's where my journey in the medical spectrum started, with working with trauma patients. After the Air Force, I came back home and I went to UTPA. Back then it was UTPA, now it's UTRGV. And I went to nursing school. So I got my RN from UTRGV. After that, I left the Valley again and went to go live in Maryland. While in Maryland as a new nurse, I started with the University of Maryland Shock Trauma Center. So where do you think I'm working at again? I'm working with trauma patients. And that was a pretty interesting experience for me. As you see there in the picture, most of the patients, it's in the Baltimore area. So it's downtown, you have high-rise buildings. The way they bring in our patients into the medical center there would be either by helicopter or of course by ambulance. So as you see in that picture, they would arrive onto the roof and bring them into the hospital to get treated. So I did a couple of years of that. Then I went back to school to get my master's with the University of Maryland in Baltimore. And I got my master's in health, leadership, management, and education in nursing. And then I came back home because we love home. The culture here is really tight, and we're very fortunate to have a really good culture here. So I came back home, and now I'm working with DHR in the trauma department. So that's kind of how my journey went with within medicine. Okay. So a couple of things that I'm going to be discussing today are, one, the trauma department here at DHR, what it consists of, what we do. I'm going to talk about the trauma patient and their care. So basically, when someone gets injured, what happens to them? How are they treated when they get here to the hospital? What are the things that we do? What are the services? And what is the recovery for the trauma patient? Then I'll go into a little bit about injury prevention, which is part of what I do as a trauma nurse as well. And then how to become a trauma nurse. So I hope I inspire you guys after today. So the trauma department here at DHR, we are a small department. We are like a quality department. We have a trauma medical director, which is a surgeon. Then we have the trauma program director, which is the nurse. And then we have a couple other nurse clinicians, and then we have trauma registrars. So the nurse clinicians, what we do, and that's the title I fall under, we do a lot of patient care. And then on the side, we do some education. We look at different charts, look at different patients that came in, and look how their care went, if things went well, what we can improve on, as well as teaching in the community. Our trauma registers, they're more behind the scenes. What they do is they look at all the patients that come into the hospital, they open up the charts, and then they have to log all the different data points that they need to be placed into a national trauma registry. So for example, when you're driving down the highway and you see a billboard sign that says 10,000 people died this year in a car accident, that's where the nation gets those statistics from all the hospitals that put in that data into the National Trauma Database. So trauma nurse clinician role. We provide care to trauma patients. So when the patient comes into the emergency room, we are there at the bedside. We not only help with the care, but we also coordinate with, do we need to get a hand surgeon here? Do we need to get the trauma surgeon right away? So that's where we come in. So not only are we hands-on, but we also do a lot of the care coordinating as well. Then we do nursing education. We provide, there's a trauma course that we have called Trauma Nursing Core Course. And most of our nurses that provide care to trauma patients here at DHR, they have to go through this course. So that's where we come in, and we also instruct that course. And we do annual skills practice with the nurses. So there's always learning going on. You never stop learning. Even after college, you're always opening books to learn. How fun, right? We also educate patients, family members. We oversee the care of the trauma patients. Chart reviews, I mentioned. We attend local, regional, and state meetings to advocate for our trauma patients and help with creating policies, guidelines, and procedures for the hospital as well. And we also do injury prevention. So the trauma patient, hopefully you have never been in a hospital as a patient, but those of few of you that probably have, you probably know a little bit how this goes. So the trauma patient, there's different mechanisms of injury, the way a patient can get hurt, whether it can be from a car accident, a fall. We get a lot of elderly people, abuelito, abuelita, they accidentally fall, and we get a lot of those patients that come into the emergency room. It can be a work injury. Maybe they were up doing some construction on the roof, they fall and off the ladder, and they come into our hospital. Sports injury. I'm sure a lot of you guys play sports out there. Any football players, soccer players? We do get a lot of sports injuries as well, especially with football. You get a lot of fractures, maybe leg injuries, and concussions. How many people have probably hit your head in football? Then we also have blunt trauma, penetrating injuries. This is basically anything that comes, any force that hits your body, whether it be maybe a baseball bat, a baseball, anything that hits against your body. Penetrating injuries are injuries that they penetrate into your body. For example, gunshot wounds, knife stabbings, that would be considered penetrating injuries. And then we have burns. We don't necessarily have a burn center here at DHR or in the Valley, so any critical burn, if it was a big area that was burned in your body, they would more than likely get sent to San Antonio or to Houston. So let's say there was a car accident. The patient would come to the hospital either by ambulance or by helicopter, or maybe their family member will bring them in their own vehicle. They'll arrive to the emergency room, and just like you see in this picture, there's a whole bunch of people waiting to meet and greet you. We have a lot of doctors, nurses, medical technicians. So initially the patient will come in kind of like this in the picture as you see. And in the trauma room, we'll have maybe a doctor, the ER doctor. If it's a very critical trauma, we'll have the trauma surgeon there and ready to go. We'll have about 2 nurses, a medical technician, and then we'll have lab, x-ray, and respiratory there as well. So the patient will come in. The physician will do their assessment, which is what we call our trauma assessment. They'll look at the patient up and down and to see if there's any life-threatening injuries. What we mean by life-threatening injuries are if the patient can't breathe, if there's something, maybe they suffered a really bad injury to their chest and they're unable to breathe. So at that point, we would address the breathing first to make sure they are breathing. If we need to give them some oxygen, if we need to put a tube in their mouth and to breathe for them and intubate them, that's what we call intubating. If they're unconscious and they can't breathe, we would probably intubate them and give them some oxygen and get them breathing. Then after we assess breathing, we go into circulation. Is the patient bleeding anywhere? Do we need to stop a bleed? Do we need to apply pressure? Do we need to put a tourniquet and give some care? Then we take some labs. We take some x-rays to see if there's any broken bones at the bedside. The x-ray has a little portable machine that they'll come by and take some x-rays. So that's the beauty of it's not beauty being in trauma, but when you come in as a trauma patient, we act really fast and work really fast to get you treated right away. We maybe start an IV. That way we can give any fluids in case you need fluids. Maybe you're dehydrated, or maybe you lost a lot of blood. We can give you blood or fluids through the IV. We also give pain medications or any other medications the doctor may order. And the IV access also helps to, in case you go to CT, they'll put some contrast in through the IV and be able to see some of the structures in your body better in the CT scan. Then we'll take vital signs, which would be your blood pressure, pulse, respirations, oxygen, and we also want to see what your pain is like. And if there's any wounds, we'll take care of those wounds. We'll do some wound care and apply splints to any broken bones. So this is kind of what, not this trauma room, but how it would be like when the patient's in the trauma room initially. There'll be a bunch of hands working on the person to get them well and stable. X-ray, here's just an example of a horrible head injury. You see all those nails into the patient's head. So this is what we would see on x-ray. If there's anything penetrating, we mentioned penetrating injuries into the head or anywhere in the body, we would catch it on x-ray or any broken bones. On the right here, we have the CAT scan. No, we don't put a cat into the scanner. The patient goes in through the scanner. They lay down on their back, head first, and they go through that donut hole looking hole there. And they scan their entire body to see if there's any vessel injury, if there's any internal bleeding that we can't see. And that happens really quickly. Traumatic injuries. So there's different, anytime anyone sustains an injury, there's many areas in our body we can have trauma to. A big one, like I mentioned with football injuries, are traumatic brain injuries. They may have a bleed in their head, they may have a concussion, they may not remember what happened, they black out. That's what we call traumatic brain injury. Then we have spinal trauma. Anytime somebody falls, they can hurt their spine, especially if it's maybe from 8 feet and up higher, they can have some spinal trauma. Or even with a car accident, the impact in itself will kind of throw your spine off with the momentum, and it can cause spinal fractures. Facial trauma, if you were hit to the face, let's say with a baseball bat, or if you were in a car accident and you hit the windshield, you can come in with some facial trauma. Neck trauma is a little rare, but it does happen. For example, wrestlers, clothesline injuries, they go for the neck there. So we do see a couple of injuries to the neck, but not so many. Chest injuries, that's a big one with our car accidents. If you're driving, your chest hits the steering wheel and you can come in with a lot of chest injuries. Abdominal injuries, that too, with car accidents, we get a lot of abdominal injuries. Also with gunshot wounds as well, we have a lot of gunshot wounds that go into the chest and the abdomen. Orthopedic or musculoskeletal injuries, anytime if you're playing a sport and you fall or you break a leg, or if you fall from the monkey bars, you may come in with an arm injury or a fracture. And then we have burns. Now Thanksgiving is coming up. A lot of people fry turkeys. We do get a couple of burns from frying the turkeys during Thanksgiving. Christmas too, so make sure you don't leave any candles lit or leave the lights on a lot of throughout the night. We do get a couple of house fires throughout the year. Disposition. So once a patient goes through their emergency room, we do all the scans, we do all the testing that we need to see what is going on with this trauma patient. One, if the injury was minor and it's maybe a few cuts and bruises here, we patch them up, give them some Tylenol, pain medicine, and they're good to go home. So that's step one. If the injuries were a little bit more extensive, and let's say it was a football injury, the helmets hit the head and one of the football players comes in and they can't remember what happened. So they have a little, they can't remember, a little loss of consciousness there. So we run a scan and they're still not good enough to go home. We may keep that patient for 24 hours here at the hospital. That way we can make sure everything's okay, and then they would go home the next day. Or if the injury was more extensive, they had a couple broken bones here and there, they had some bleeding, maybe a head injury. To add to that, the patient will probably need to go to surgery. So we would keep them here. They would go into the surgery suite, which is, it looks kind of like the one on your bottom right picture. So they would go in for surgery, get anything fixed and repaired, and they would stay here at the hospital with us, in which we would call it an admission. So they're going to spend a couple of days here with us to recover. So once they get admitted, we have a couple of units here at the hospital. We have the surgical unit. So basically, if you had surgery and you're not that critical and you're pretty good, you can still walk, talk, you're going to go to the surgical unit and recover until you go home. Recovery is usually anywhere from 3 to 5 days. We do have a couple patients that have more severe injuries that do stay with us for about 2 weeks to a month, depending on the severity of the injury. Then we have our telemetry unit. If you see that top picture on the right, top right, that's a telemetry monitor. So anytime, for example, we are thinking injury to the heart, or the patient has other illnesses, for example, diabetes or any heart conditions, and they sustain a trauma, we may want to keep them in the telemetry unit. That way we can monitor their heart rhythm throughout their stay, making sure there's no changes, or make sure they don't go and have a heart attack or anything like that. So we monitor their rhythm. And then we have the critical care units. So in the critical care units, that would be the more severe trauma patient that would stay in a critical care unit until their recovery. Recovery. So once the patient got well, they stayed with us, they had surgery, then they're ready to go home. So if they're good and able to go home, they go home and maybe have some home health help with any wound changes, any dressings that need to be done, and they'll just come and follow up at the trauma clinic time to time after their recovery. If the patient got discharged and they need more extensive rehabilitation, we have the trauma rehab hospital, as well as other rehabs here in the Valley that they can go to. And like you see in the picture here at the bottom, this individual did have an injury. And what you see there, what they're doing is they're using like a skeleton. They call it an exoskeleton. We have it here at DHR Rehab. And it's basically helping them, it's walking for him. So they strap him to the suit, and as he's going, the skeleton is helping him move his body. So especially with our traumas that have severe brain injuries, sometimes it's hard for them to be able to do things on their own again. They have to learn everything all over again. So in this case, they may need some rehabilitation to help them walk, to help them speech therapy, to help them just do simple things that they do every day, like you and I do, bathe themselves, cook and clean, and all that good stuff. Psychosocial aspects and support. The trauma patient or any patient that comes into the hospital is pretty devastating to them. Usually everyone's well and able-bodied. So when you come to the hospital, it's debilitating. You're used to doing everything on your own, that now that you've suffered a traumatic injury, you have to have someone help you now. Maybe before you used to drive on your own, and now after the trauma you can't. So it's going to take a while for this patient to recover. But the more support they have, the more classes they attend in their rehabilitation to get them back to normal, that's going to be the best outcome for the trauma patient. How to become a trauma nurse. So basically, we're nurses. You would need 2 years of your basic college courses. On top of that, you would apply for a nursing program, do 2 years in a nursing program. If you want to do frontline emergency critical care, they usually require about 2 years for you to be on the floor, which means 2 years in a medical surgical unit, something less strenuous, something less critical. That way you can get that basic care experience as a nurse, and then you would be able to move on into the emergency room or critical care area. That's typically how it works. But if you don't want to do trauma nursing and you just want to go into any other field in nursing, basically your 4 years of nursing school. There are some exceptions. Some hospitals have a trauma nurse residency program. And what that is basically is after they graduate college, after nursing school, after the 4 years, as a new nurse, you apply to this. It's usually about a year-long program. You get hired by the hospital as a new nurse, and throughout your first year, they give you projects. You go around and work in different areas in the hospital for a couple of months and see which one interests you, which one you excelled at, and which one you are most passionate about, in which that would be the exception where you may be able to start in the emergency room or critical care area a little bit sooner. Trauma prevention. So that's another thing of what we do. We do injury prevention. We give motor vehicle crash prevention. For example, the #1 leading cause of crashes, not only is it drunk driving, but now it's also distracted driving. We have, a lot of us have cell phones now. We use our cell phone while we're driving to answer an important call, or maybe we may come to the stoplight and pull out our phone and answer that text. So they're really trying to discourage any distracting driving. That can also include talking, not paying attention to the lights, to the pathway, and maybe being distracted with the people in your vehicle. So we go a lot into motor vehicle safety, making sure we wear our seatbelts as well. Then we have bicycle safety. A big thing with bicycle safety, we have a lot of bike riders out there that do it as a workout. You always see them out there with safety helmets and reflectors. Not so much is it the person driving the bike, but people may come and accidentally not see the person on the bike and they get hit. So we stress a lot about bicycle safety. Fall prevention. Fall prevention a lot with our, like I mentioned earlier, abuelito, abuelita. They're on medications or they're a little bit slower. They have slower reflexes. So we get a lot of patients that come in for falls in that population. Swim safety during the summer, drownings, we deal with that as well. We educate the community to be able to monitor the kids, making sure that they are within the depth level of the pool that they can handle. Recreational activity safety, ATVs. There's a lot of people that use ATVs, especially teenagers. They go out and it's a small motorcycle. They go out on an ATV and they don't wear helmets. We do get a lot of patients come into the emergency room with very bad injuries from ATVs. Then we have the holidays coming up. Holiday safety. I mentioned about the turkey, frying the turkeys, the Christmas tree lights, making sure we have those in well and working order, so that way we can prevent any fires. And lastly, we also have Stop the Bleed. A lot of you guys did get the Stop the Bleed lecture within your training here with DHR. So that's what I'm gonna go into a little bit more. So I'm basically gonna do a Stop the Bleed review. If you remember from your hour-long course last year, we did a presentation. We also did some hands-on. And remember, first, you always want to ensure your safety. Make sure it's safe for you to be able to give care to anyone around you. Then we're gonna A, alert, call 911. B, identify the bleeding. And C, compress the injury, whether it be by applying pressure, packing, or applying a tourniquet. And lastly, we're gonna wait for help to arrive. But remember, we never loosen any tourniquets, take off any tourniquets, or release any pressure at any point in time. We wait till help arrives. And again, here we have our ABCs of stopping the bleed. I'm going to show you a little video, just a refresher on applying pressure. So right here, it doesn't have any audio. There we go. So if you have a superficial wound to any part of the body and you don't have any other equipment with you, you can always use any piece of garment, a t-shirt, a jacket, and hold pressure on top of the wound. And that's gonna stop the bleed. That way the patient doesn't lose a lot of blood and possibly go into shock and have a poor outcome. So that's her applying pressure. Then we're going into wound packing. So let's say you have a deep wound to your thigh. Maybe you were out there putting up the Christmas tree lights and you accidentally slip off the roof and your way down something stabs you in through your leg, and now it's bleeding really extensively. So then we have, if you have a deep wound, right there she's using Quick Clot. And a refresher with Quick Clot, it has a chemical in the bandage that once it makes contact to your skin, it allows it to clot faster. Now, do you need Quick Clot to pack a wound? No, you don't. You can do with any piece of large clothing, a t-shirt, a jacket, tablecloth. You can just go in, as long as you go all the way deep into the wound. After you pack the wound, then you're going to compress and hold pressure as well. And then you have your tourniquet application. And here she's going to use a cat tourniquet. If your injury, remember again, if your injury is anywhere to your arms or your legs, you can use a tourniquet. So this is a cat tourniquet. She's going to thread it through the hole, just kind of like a belt. Wrap it around and attach it to the Velcro. And then she's going to take that rod and twist it all the way until the bleeding stops. Depending on the size of the person, you're not going to, if they're a little fragile, they have little arms, you're not going to say, I'm just going to turn it twice. No, you're going to turn it until the bleeding stops, and it will hurt. And then with the remainder of the excess that's left, make sure you wrap it around and keep it tied in place with that time strap, that white time strap. Then you write the time on there. And that's for the reason we write the time on there is to help the surgeon know how long that tourniquet has been placed on this patient and what type of treatment they need to do to save the arm or the leg. Okay, so now there's a new Texas House Bill 496, and that has gone into effect. It was placed about around this summer. And now it's out saying that all public schools and charter schools in the state of Texas need to have a Stop the Bleed kit in their campus. Along with that, the schools also need to have the staff trained in Stop the Bleed training, and all 7th graders and higher need to also have gone through the Stop the Bleed course. Unfortunately, because of the different things that are going on in this country now with the school shootings, this is one mandate now that Texas has put into effect in order to be safe and be able to give care in case anyone is bleeding. But this doesn't just pertain to school shootings. Like I mentioned, you can have injuries from bleeding in any other case. For example, your athletics, you're running, soccer players, your ankle gives out, then you have an ankle bone that's protruding out and accidentally cuts an artery in your leg and you're bleeding out. So we also have a lot of those instances where you can use this Stop the Bleed training. So this is to go in effect January 1st, 2020. And this is a snip of this House Bill 496. And this snip shows the different equipment that need to be in the kit there at the school. So here's a picture of all the supplies. So on the top, you have your CAT tourniquet or the tourniquet that your school district decides to go with. A quick clot, which is a hemorrhagic hemostatic dressing. Then you have on the bottom there, you have a chest seal, which I will go over in a few slides. You have your scissors, your nitrate gloves, an emergency blanket up on the top right. That's called an emergency space blanket. And then on the bottom, you have some Curlix. So all this equipment is to be placed in a kit out at the schools. And depending where the nurse decides or where the principal decides to place those kits, usually they put them next to where they put the AEDs, or they may be in the nurse's office or anywhere where there's a large crowd, like maybe a cafeteria or a gym, depending where the nurse and the administration decides to put those kits. So those will be coming out this year. Then we have the Texas School Bleeding Control Kit and other supplies. So on top of the Stop the Bleed supplies, Texas went ahead and added these two items that I mentioned earlier in the previous slide. They added the space emergency blanket. So it's basically a thermal blanket to keep you warm. Anytime you have large amount of blood loss, you do get cold. I know people will say, well, we're in Texas, it's not cold, it's hot. Well, today it was a little cold. So if you lose blood, so basically blood is what's keeping your body warm because it's circulating throughout your body. So if you lose blood, then you're going to start getting cold. So that's what this space blanket, emergency blanket is going to do, is keep you warm and buy you some time to get to the hospital. The chest seal is designed to temporarily assist with certain types of chest wounds, and I'll go over that in this next slide. Okay. So avoiding hypothermia with the blankets. So the patient can lose body heat rapidly after the injury, like I mentioned. A life-threatening heat loss can even occur on a hot and summer day. So once the bleeding has been stopped, which either it be compression, packing, or applying the tourniquet, then you would remove any wet clothing if they have any clothing that got wet, and cover them with a warm with a blanket. If you have a warm blanket, great. But these, like I said, these blankets would be in the emergency kits at your school. So essentially what it does, it's a reflective blanket. They use it a lot for camping, people that go camping. There's many different usages that you can do with this blanket. It can maybe shield you from the sun on a hot day. But here what we're talking about is after blood loss. You become hypothermic, you become cold. And that reflective blanket, what it's going to do is going to reflect the heat off your skin from your body into the blanket and back to your body. so it's reflecting the heat. Then we have the chest seal. So with the chest seal, this is what it looks like. Anytime you have an injury to the chest, hence the name of this bandage, it's called chest seal. If you look in the middle of that picture, there's a center vent that basically, so when you have any injury to the chest, we would place this dressing on there to help your lungs, and your lungs keep that inflation as you're breathing. And that way no extra air goes into your chest as you're taking that deep breath. And it would buy this person some time to get to the hospital. So how we put these on, here we go. So we would, if there's any injury to the chest, so here on the top left picture, you see a hole to the patient's right chest. We would clean off any debris. Oh, did it move? There we go. Okay, we would clean off any debris, any dirt, anything that may be dirty around there with a gauze. Then we would go on with this, it's an adhesive, kind of like a sticker. You peel it off and then you stick it on there. And you center it. The center of the dressing should be on top of the wound. And that's if there's any injury to the chest. Now, can you put this on the abdomen? I mean, you can put it in the abdomen, but it's not really going to do anything. The main thing is to help our lungs keep that inflation and deflation as we breathe. Okay, here are my references. And then here at the end is the DHR Trauma Services. So this is my phone number and email if you have any questions. If maybe one of your teachers is interested in the course, the Stop the Bleed course, or has any trauma questions, you could be happy to email me. Or if you just want more mentoring on, Jen, I really want to be a trauma nurse. What pathway can I take? Feel free to email me and I can help you out and give you more guidance with that. Okay, so now I'm going to open it up for any questions. I'm going to turn off the slide and I'm going to put myself back on the screen so you can ask any questions that you wish to ask.
So students, there's two different ways that you can ask questions. You can either unmute, and you don't have to open the video if you are uncomfortable with that. And you can ask the questions live, or there's a chat feature. If you put the cursor at the bottom of the screen, a toolbar will open up, and one of those tools is chat. Just click on chat and you can type in your questions. So does anyone have any questions for Jennifer this morning? I see we have Miss Conde's room in Harlingen. We have another Harlingen user here. Any questions?
Yeah, we have a question for Jennifer. So me and my friend David, we're competing in a HOSA, and our video is to stop the bleeding. We have a question on what we could do, like improve our video, like scenarios we can include, stuff like that.
So you created a PowerPoint or a video and you wanted to put some scenarios in your video?
Yeah, exactly. We're creating a video and we want
For
to
stopping the bleed. Okay. So basically, anytime there's injury to a vessel, you want to definitely have in your video. A good one is, I mentioned sports injuries with, for example, a soccer player. They're running, they accidentally hit someone else and their ankle twists. So as their bone comes out through their ankle, it can accidentally cut a vessel and you can have a lot of bleeding. So there's one. Thanksgiving is coming up, so we're well within that time frame. A lot of injuries that we get with Thanksgiving is mom, dad, or whoever is cooking, they're cutting the turkey and they accidentally cut their finger or they cut their slice their hand, and which creates a lot of bleeding. So that's another good scenario now that we're into the holidays. The other one would be one that really no one likes to hear about, but a shooting, or if there's any penetration to the body, whether it be by a knife, a gunshot wound. So those are a few that you can go with. I think the turkey one is probably the good one.
We have
Does
a
that
question.
help?
We have a question in the chat, and it says, one of my students wants to know if salary differs in the departments for nurses, like trauma and neonatal.
Yes, definitely. Depending what route you take, depending where you work at, your salary will differ. As a new nurse, you're still going to be earning a little bit less than a nurse that has been here 20 years. But as far as departments, they do vary. So if you don't deal with critical care, let's say medical surgical, telemetry, or a clinic, those salaries are going to be just a little bit less than if you were to do any of the critical care or specialty areas. One, the patient is going to be more critical. You're going to have to be working a lot more in these areas that get higher pay. Two, you're always going to have to be keeping up different certifications. So don't think just by going to nursing school, I'm done. No, it continues every year to 2 years. You have to be doing trainings, a lot of extra trainings to keep up your medical knowledge. Also, medical knowledge changes, so then they bring out new classes, new courses, so that you constantly have to be taking to upkeep your nursing knowledge as well as your practice. So definitely critical care, ER, specialty areas do pay a little bit more, but they also require more work, more stress as well. But it's doable, and you guys, I'm sure, are really smart and will be able to get it done whichever route you take, or just find whatever passion, whatever you're passionate about. If you feel you're more passionate about pediatrics or about babies, neonatal, go with the route that you want to take, because at the end of the day, you can make a lot of money, but if it's not something you want to do, it's going to be very stressful. So yes, the different areas do pay differently.
I think someone in Ms. Conde's room has a question. Yes?
Yes.
Go.
I was wondering if you would have gone to college first, or if you wanted to enlist straight away into the Air Force.
Can you repeat that last part?
If you would have gone to college first, or do you regret not going to college first and then enlisting into the Air Force?
If I would have gone to college and then gone to the Air Force, probably not. I don't think I would have probably gone that route, just because realistically, the culture that I grow up in, we're very tight knit. So me leaving off to the Air Force was very hard for my family and for myself as well. But I think if I would have stayed here or even gone to college first, I don't think I would have gone into the Air Force. So it was unexpected, but I think it was a great decision that I made for me at the time. And it has led me to where I'm at now. And it's given me so much training and benefits and educational grants and things like that to pay for my schooling. Actually, all my schooling has been paid by the military, from my bachelor's to my master's. And hopefully I can get it paid for my doctorate. So, but yes, there's different routes. Would I have gone to the Air Force after college? Probably not.
Thank you.
We have another question from Hidalgo ISD, and it is, how many trauma surgeon does DHR have, and what are the shift hours?
Ooh, shift hours for the surgeons or for the nurses?
Probably both, to be honest.
Okay, I'll tell you a little bit about both. So let's start with the nurses. The nurses, usually our main trauma core nurses are usually in the emergency room. That doesn't mean that if you work in the OR or in a critical care area, you're not going to be taking care of a trauma patient. You still will see that patient at some point within the hospital if you work in some of those other areas. But the people in the ER, they get a little bit more extensive training because they see the trauma patient initially with all their fractures, whatever vessels may be bleeding. So they have a little bit more training as to how they need to control those things. So normally a shift hours would be, if you work the day shift, shift starts at 7 in the morning. So which means you would have to be here by 6:45, because what happens in the morning, you get report from the previous nurse that was there before you on those patients that were there. And then you start your day about 7. So you have to get here before 7, even though it says 7 in the morning, to 7 p.m. So you go your 12-hour shifts, then at 7 p.m., same thing, you give the report to the next nurse that's coming for the night shift. And a lot of times, it's very crazy and chaotic during shift change, to where you kind of don't get out at 7, even though your clock or your time says 7 to 7, and your family at home is waiting for you at 7, and they tell you, you were supposed to be out at 7, where are you? And it's already 8. So sometimes it does end up being 13-hour days, but for the most part, it's a 12-hour shift for the nurse. For the physician, that's a little bit more working hours, a lot more actually. And their hours, I really couldn't be able to tell you. Normally for them, typically it's a 12-hour day, but it ends out being more like a 16-hour day, because they have more either emergency surgeries or things they need to round on their patients if they haven't gotten to it. How many days a week they work, it depends on how they set their schedule. But like I said, maybe for a surgeon, you'd be looking at 16-hour days. How many surgeons we have here at the trauma center? We have about 8 trauma surgeons now. So we're getting those numbers up because our patients, we've been getting more injuries, more patients that come in with trauma injuries, and our numbers have been growing. So we have 8 now, and they rotate, and they're always busy. They're always getting called.
I have a question. I know that I heard on the news something about DHR being a certain level trauma center, or going to be a certain level. Can you explain what that is?
Yes, definitely. And good thing you reminded me. I did forget to put that on the slide. That is very vital. So the way the trauma system works is nationally, there's different trauma levels. It goes from 1, 2, 3, 4, and I believe Texas even has 5. So what that means is if you're level number 1, you're gonna get everything and anything, all the most ugliest, critical, severe traumas. Your facility has the resources, which means the surgeons, hand surgeons, ortho surgeons, eye surgeons, everything that you need to take care of those patients, as well as the nursing staff, and making sure that everyone is well trained to take care of those patients. Along with being level 1, you also have to do teaching to the community. You have to not only teach the community, but kind of like we're doing here, be a mentor to the other facilities, the other hospitals around you that are not as big, that may not get a lot of trauma patients. So you would also be teaching those and mentoring those around you as well. Along with that also comes research. So with research, we also need to have a partnership with a university. And now UTRGB, the medical students from their medical school do come and practice and do some residencies here. So we have a lot of residents on site now to with that partnership with UTRGB. So those are the lot of things that go into being a level 1. Then you have level 2. Level 2, basically, you're kind of like level 1. You just you're not really doing that research. And you may not have a lot of those other resources either. But for the most part, you should have a full trauma surgeon staff, orthopedic surgeon, neurosurgeon as well. Then you have level 3. Our level 3s are also kind of like our level 2. So you're kind of like the step up, but you just don't have as many resources as you would need to take care for that patient. So basically what that means, if you're at a level 3, level 4 facility and you get a minor trauma and you can take care of it there, you can keep that patient there. But if it's a severe trauma, you may have to send that patient out to a level 2 or a level 1 where they can have all the resources to take care of that patient. So what it means by DHR acting level 1, at this point we are acting level 1. We do have a lot of the resources that we need to become a level 1, but it's just a big process that goes into effect with legislation, partnerships with the EMS companies. We do have a lot of, like I said, a lot of the resources, the trauma surgeons, ortho, neuro, hand surgeon, eye surgeon. It's just a matter of time before, it's like you're prepping for a test, what we call a survey in the hospital industry. So some surveyors would come and they would see your hospital, see how it's functioning, look at some cases and see if you are able to keep up that level in order to provide that care to the community. Does that, do you have any more questions? Is that clear?
Yes, that was very clear. Thank you. I think we have another question from Ms. Conti's class. Yes?
Yes. So I have a question for Mr.
Yes.
Schreiber. Me and my group, we wanted to ask if there was ever like a patient that greatly impacted you.
I need you to talk a little louder.
Yes, I can hear you guys.
If there was a patient that ever like greatly impacted you or left you like, I don't know, just that what? Like mentally affected you in some kind of way?
So it's tough being in any of the critical care areas, or not just in trauma, if you're working with oncology, which are cancer patients, or if you're working with pediatrics, especially now I do have a 5-year-old. So anytime we get pediatric trauma, knowing that we're getting a kid does impact me, just knowing that we're getting a kid, because I think of my own too. Or my nieces and nephew. So you just have to, when that patient comes in, for example, let's say we were to get a 5-year-old today in the emergency room, as a nurse, or working in the emergency room or critical care area, you build up that resilience to be able to take care of that patient when they come in. So I think a big one would be a pediatric patient that would come in. So you zone in on all your training and you look at the patient as they come in. Are they bleeding? Do they need oxygen? And you just quickly act on that. But as far as impact, when I was in the military, I did have this 20-year-old. He was a soldier. I was in Maryland, DC, one of the hospitals up there next to the Capitol, and we got this patient. He was obviously a soldier. He had gotten shot a couple times in his abdomen, and I was right about his age, and it was just weird taking care of someone around my age, and seeing their injuries. He had a couple of holes in his abdomen. His family was really nice there at the bedside, giving him support, but just knowing that we were about the same age and this is what had happened to him, I think that really impacted me and definitely drove me more to consider and have more passion in the career pathway that I took with trauma. So.
Thank you for your question.
Thank you.
Do we have any other questions? We're getting back to the top of the hour, and I want to give a little opportunity. I don't want to miss any questions that are out there, because this is the only time you can ask the questions directly. You have to watch the Cyber Mentoring live to be able to either ask questions live or put them in the chat. After the recording's over, your chances are over with.
Ask away, ask away.
It sounds like that's it, Jennifer. I want to thank you today for joining us. All the information you gave was very interesting. I think it's awesome that you told us about Texas House Bill 496, because I wasn't aware of that, and I'm getting ready to go out of my office and go talk to my administrators to see how we can support that.
Yes, it's a big thing, and not just you, but all of Texas is rambling around to try and get this training and see who offers it. We do offer it here at DHR, or I can actually go out to the schools and give this training, and I coordinate that with the schools as well. And thank you so much for having me here this morning. I hope I inspired someone to not only become a trauma nurse, but become a nurse or anything in the medical field. Doesn't matter how long it takes you, but once you find your passion and work towards it, you can do anything that you wish to do.
Well, I'm going to unmute Miss Conde because I think that class wants to give you a big, or maybe they have to unmute themselves, a big applause. Go ahead and unmute yourself and give her some applause, guys. I saw you doing it.
Okay.
Thank you.
I want to thank everyone for joining us this morning. It's November. Let's have a great rest of the semester. We will be back on December 6th when Doctors Hospital at Renaissance will have Dr. Auer with us, and he will be talking about physical therapy. Thank you, everybody. Goodbye.
Bye. Thank you.